Hello? Oh, yes, actually, it was Brad. He had the order. They would call you yesterday. Yeah, the one for the order yesterday. And I just texted Brad. Thank you.
Morning.
Oh, really? Uh-huh. I think you correct some histopathology.
What's that?
Some histopathology you correct me.
I know what it is, yeah.
Try my best.
Good morning. I got to sit at a table today. Last week I was late.
Better than the more, certainly.
Oh,
Better than the more, certainly.
what are you doing?
I thought I would learn some stuff. Because, you know, once in a while there are impacts. So.
1 and 3. Oh.
Oh, the third one. Oh. Yeah, 1 and 3.
Good morning.
thought that it's a boring topic.
Well, I stayed over an extra day to hear it. It'd be good. Did you hear about the Mr. Clean trial? No. Intervention proved out.
Oh yeah, the one I heard that.
I didn't hear about the Mr. Clinton trial.
Well, I printed it off just yesterday because it was mostly new to me. I've heard bits and pieces of it. But the bottom line was the intra-arterial approach was better than IV in a big controlled trial in the Netherlands. An extra 15% better outcomes. So, that's the first one that was truly well done trial. Oh.
Well, it would be interesting to compare that with administering it IV in the ambulance when the patient doesn't have to.
Yeah, it's a little different rate.
Make them even more balanced.
If the only person I know doing that is Jim Grotta. He rides the ambulance out there to deliver himself personally.
There was just a report saying that that's just not going to be practical. That what they say is we're going to have to set it up to where the ambulance can communicate with the stroke doctors in the hospital, just like they do between emergency rooms and the hospital.
Yeah, I think Jim just wanted to get out of the house, run around in Houston. Novel people were off, and now he wants to go back to his office.
Let's see, what's his last name?
Grotta?
Yeah. You know, he was a candidate to become chairman.
He's first rate. I couldn't even imagine him not being in Houston because he's so everything up this huge funding, huge team, huge population.
I don't know whether he just wasn't taking or he dropped out. I don't know. The other thing that his group has been for over a year is breaking the assumption that the stroke occurred when we went to sleep. They're treating those people, assuming that the stroke occurred when they woke up, not when they went to sleep, which brings more into the window of time to give.
Well, we had one of those 2 weeks ago on a Friday morning at 3 o'clock someplace. Mountain Road somewhere. Had a patient wake up and suddenly looked like it may have been that very moment. She was treated with IV TPA there and transported down here. So that was 3 a.m. At 8 a.m. we had pulled the clock out of the MCA. She went from an NIH score of 28 to 10. There was a big clot. TPA had not gotten it. She was an AFib patient who was not on the
Yeah, I think
whole piece of
Good morning, everybody. I'll talk about hereditary vasculopathies. It will be mainly clinical part, like more than like fancy studies and numbers, more of a clinical approach of how to think of these uncommon cases, when to build up the front when we are encountering these conditions, like a stroke, or minor strokes, or dementia patients, who have cryptogenic cases. That's what we are trying to build up an approach to. So basically, there is no disclosure here, and start. Epidemiology of stroke in the young. So stroke in the young is an uncommon condition, and it accounts for barely 10% of the whole cases of ischemic strokes. And the definition of stroke in the young varies among people, among different epidemiological data. Some patients, some studies mention that the age cutoff is 40 years, others it's 50 years. And as with the age group between 20 to 40 years of age, 20 to 24 years of age, it accounts for 2.4% of 2.4 in 100,000 cases of strokes. And in between 30 to 34 years of age, their number increases slightly, around 4%. But around 40 to 45%, 40 to 45 years of age, the risk increases up to 32%, 32 per 100,000 patients with stroke. That's what we have discussed here. Now, the genetic causes of stroke are very low. The very low number of the cases of genetic causes, but the most common ones are drepanocytosis, which is a cause of ischemic stroke in African populations, as well as sickle cell disease, are a common cause of genetic causes of stroke. But we will not discuss these conditions. Well, CADASIL have been reported to be around 2% to 2% of stroke and small cell disease combined. And Fabry's disease is another, like, common of the uncommon causes of ischemic stroke. It's found that in a study of 493 patients with stroke, they found that 2.4% they carry the genetic mutation for Fabry's disease, which is alpha-galactosidase A deficiency. And stroke occurred in these patients in 1% of volunteers, so that 0.1% of the whole stroke cases have an alpha-galactosidase deficiency. So now, when they studied patients with Fabry disease, they found that the higher the cryptogenic cases, there will be a higher number of Fabry cases. And if there is no hypertension and the patient stopped to have those strokes, there will be a further higher number of Fabry disease cases will be detected. And if the patient and the stroke, if it's correlated to the posterior circulation and it is more of a lacunar type, it will be correlated higher. It will account for around 12.5% of these cases to carry Fabry disease. So another study in the Baltimore, Washington region, it accounts for 0.16% of all cases of stroke and 0.65% of all cryptogenic stroke. So it's correlated with the number around 3 times higher with the cryptogenic strokes compared to the all lacunar strokes. So, family history is very important, and it has been found that it accounts for around 2-fold increase. Whenever there is a family history, it will increase the risk of 2 folds. And for paternal history, it's around 2.4-fold increase and 1.4-fold increase if there is a maternal history. Dizygotic twins around 17.7%. There is a concordance rate, as well as the dizygotic twins is 3.6. That makes how much the importance of genetic factors in the risk of stroke. Ischemic ICH, we'll not discuss ICH, we'll discuss more of an ischemic stroke cases, but they found that up to 6-fold increase in first-degree relatives with ICH, they will have also intracranial hemorrhage too. And the patient with subarachnoid hemorrhage also, there is a 4-fold increase in subarachnoid hemorrhage risk in patients with family history of subarachnoid hemorrhage. Now, the cutoff point that that found that to be relevant for family history for stroke, it's around 65 years. It almost resembles the coronary artery disease cutoff point. So there are several forms of studies that have been implicated to study the genetic associations between diseases, these including candidate gene studies. These are the first studies that have been utilized to check for the risk of stroke. They use the genes that are related to hypertension, thrombosis, homocysteine, and other coagulation factors. But the problem with these studies, they were small number of patients, they were not replicated, and But with time, that these are the initial studies, maybe in the 70s, and now with time they became more for multi-stage studies and more of a meta-analysis of all these studies have been implicated. And they found that there is association between MTHFR gene and as well as ACE variants, and factor 5 variants have been implicated for ischemic stroke risk. Genome-wide association studies, these are the most commonly implicated to check for common variants of single nucleotide polymorphisms. Single nucleotide polymorphisms are the most common form of genetic mutations, and I will discuss what are they and what they are categorized for. They are used by the large number of stroke cases with family structure, and then they indicate a large number of repertoire of single nucleotide polymorphisms, and then they will check the loci of the genes that have been affected. And for these studies, they found that 6 single nucleotide polymorphisms in chromosome 9q21 have been associated with ischemic stroke. It's more of an atherosclerosis, increased risk of atherosclerosis, and 2 single nucleotide polymorphism on chromosome 425. It correlates with PITX gene. This gene is involved in the synoatrial node development as well as conduction of the action potential, and that's have been found to be implicated in patients with atrial fibrillation and as a risk factor for atrial fibrillation. Cryptogenic cases of of stroke. Some people they say that testing for this kind of single nucleotide polymorphism may be detect these cases of cryptogenic cardioembolic strokes, but still they did not found a clinical application for testing for these genetic mutations. But Codrilla studies, they tested around 144 single nucleotide polymorphisms collectively with their genotypes or imputation. That means that the single nucleotide polymorphisms are lower number, so that they will average it, they will manipulate the number so that they can uncover some genotypes. So it's just to increase the number of single nucleotide polymorphisms used in the study. So collectively, all these mitochondrial variants, they increase the risk of stroke, but not a single variant have been found to be associated to increase the risk of stroke. Familial aggregation studies is the same thing for candidate gene studies. So now, the genetic disorders, they are divided into monogenic as well as Mendelian inheritance and non-Mendelian inheritance. So for the CADASIL, which is CARASIL, which is cerebral autosomal recessive arteriopathy with subcortical and part leukoencephalopathy, it's as well as HERNS, which for hereditary endotheliopathy, retinopathy, nephropathy, and stroke. These are from small vessel disease, and they occur in 1.98 in 100,000 cases as a prevalence for CADASIL. CADASIL is a very rare condition. It's reported around 80 case reports so far, and it's mainly in the Japanese population, although there is just 1 case report in a Caucasian patient. HERNS is another rare disorder, like there is no data about prevalence. The small and large vessel diseases, according to the TORS classification, the major tires in this category is Fabry's disease, pseudoxanthoma elasticum, and neurofibromatosis type 1. Fabry's disease, which is an X-linked recessive, X-linked disorder, there's a variable studies for the prevalence depending on the clinical presentation. With classical features, it accounts for 1 in 40,000 population to 1 in 17,000. But a Scotch study, they did screening for neonates, and they found it occurs in 1 in 3,100 male neonates. They found to have to carry the genetic mutation for Fabry's disease. The interesting thing with Fabry's disease, they have variants, and they just present with the strokes later on in life. So it has variable presentation, and some people they mention that Fabry's disease is actually underestimated, especially with the renal manifestations and the cardiac manifestations to be involved in that maybe correlated with Fabry's disease. Pseudoxanthoma elasticum is a rare disorder, usually present in childhood around 13 years of age, and they present predominantly with the cutaneous manifestations, although retinal manifestations can be found as well as cardiovascular risk. In fact, cardiovascular manifestations can be seen too. Large vessel disease, which is familial moyamoya. We discussed moyamoya last year. So, which is a rare disorder occurring mainly in Asian populations, although it's found everywhere, all over the globe. So, now these are important. Single nucleotide polymorphism. It's the most common variant of genetic mutations. It's due to problem with replacement of one base pair, so resulting in change in the amino acid structure of the change in the amino acid structure. The amino acid structure can be synonymous or non-synonymous. Synonymous means that the structure of the amino acid chain will be altered through mRNA splicing or premature termination of transcription. Minor allele frequency is another. So any allele, it can be into two types. The major, it can be divided into major, which occur in the most common in the general population, and the minor. And the minor is divided into common frequency of more than 5%. It's common, less common, or uncommon. It's between 0.5 to 5%. Rare, it's less than 0.5%. And private, which is just occur in single families. Imputing, it's the method that I described about single nucleotide polymorphisms in the genetic studies to be manipulated so that to increase the number of to discover these genotypes. Penetrance, it's how much the genetic genotype can influence the phenotype. And linkage to equilibrium, the single nucleotide polymorphisms, they tend to cluster or come together so that they become more of a block, and that can be used for imputation. Endophenotypes, these are intermediate stages of phenotypes, and they can be used for risk factor for strokes. So endophenotypes, these including intermediate thickness and the carotid artery disease, have been formed for the most important endophenotype. And the intermediate thickness, wall thickness can be checked through Doppler ultrasound, and it has been found that it's the heritability between 0.3 to 0.65, so that it has a high rate of heritability among the general population. Leukorrheusis and small vessel disease, it has been found that there is a high risk with a meta-analysis of 46 studies, hazard ratio of 3.3 for ischemic stroke and 1.9 for dementia and 2 for death in patients who have small vessel disease and leukorrheusis. And they found that they screened 46 polymorphisms and they did not find any association. MRI defined in part. They think it could be related, but they did not find any in a large cohort of population of 9,400 paid participants. They did not find any association with the studied loci and MRI. So, non-Mendelian here, I know that's still boring with all these writings, but you will see more pictures now. So, chromosome 16q29, 22, this has minor allele frequency of 19% and increased the risk of cardioembolic strokes, and locus, as we discussed. 4q25, it's another one that we have discussed so far. And as you can see, all these numbers, 20%, 30%, 16% of the general population, they carry the mutation, and they increase a little bit the risk of stroke. But still, we don't know, screening for these variants will be important for predicting what kind of strokes. Okay, so monogenic disorders, CADASIL, cerebral autosomal dominant arteriopathy with subcortical and part leukoencephalopathy. It's due to mutation in Notch3. The mutation affects the epidermal growth factor tandems and it's thought that this Notch3 affects the vascular smooth muscles development as well as arterial development. And what happens that they will be accumulated, and this will result in more loss of vascular reactivity, resulting eventually into stenosis and final occlusion. So this is the pathology of CADASIL. As you can see, this is an electron microscopy, and this is the arterial, and this is the small artery wall, and these inclusions are for the This is another stain here. As you can see, it's in the wall of the artery. So these can reveal the thickening of the vessel wall with degeneration of the smooth muscle cells and aggregation of the MACH3. These are the brown-red kind of staining. Carousel, it's thought to be due to HTRA1 gene mutation involved in the transforming growth factor beta signaling pathway, and with this mutation will result in, so the HTRA1, what happens that it suppresses the transforming growth factor beta pathway. So whenever it's mutated, the transforming growth factor beta pathway will become more activated, and this will become more fibrosis of the wall, resulting in stenosis as well as development of strokes. Burns, this is due to TREX gene mutation, and it results in more of a lamination of the basement membrane found in the retina, kidneys, as well as the skin. Fabry disease, we have this, it's due to alpha-galactosidase A deficiency. Alpha-galactosidase A deficiency, and it produces accumulation of the global triacetylamide. These will result in dysfunction of the smooth muscle cells as well as changes in the skin too. So this cartoon reveals what kind of genetic and what's the locus that it acts for. So, for example, patient abnormal vascular homeostasis for MACH3 as well as for HERNS, transforming growth factor beta. The ABCC, which is due to pseudoxanthoma elasticum, it will result in degradation of the reticular meshwork of the blood vessels as well as calcification, resulting in increasing the risk of stroke. The homocystinuria and homocystinemia and Fabry disease, the accumulation of these will affect the wall, resulting in dilation of the wall with resultant atherosclerosis as well as emboli that can be showered. So this is a microscopic picture of Fabry disease. As you can see, these are laminated granules. It's in the lysosomes. It's a lysosomal storage disease. So the abnormal, the alpha-galactosidase, mutated alpha-galactosidase will be stay in the cell, and this will result in electron microscopy as laminated bodies. And some people, they mentioned it's like zebra deposits. This is another picture of the glomeruli of patients with Fabry disease. They pointed to these laminated bodies, but I barely see it. So this is a histopathology of pseudoxanthoma elasticum. As you can see, there is calcification with these blackish deposits, as well as disorganization of the dermis. Familial moya-moya disease. Moya-moya produces more of thickening of the intima, as well as with duplication of the internal elastic lamina, resulting eventually in stenosis and affecting the internal carotid artery and then circulation. Arterial dissection is caused by predominantly with the Hereditary syndrome as well as Marfan syndrome. So MELAS, which is due to it's one of the causes of metabolic cause of stroke, and it's due to tRNA mutation for the leucine. There are several theories of how mitochondria can produce stroke-like episodes, and including mitochondrial cytopathies, which is just energy failure. The most interesting one is mitochondrial angiopathies. These patients with MELAS, they found that they have increased staining for something called cytochrome C, and compared to other mitochondrial disorders like Kenstein syndrome or liver hereditary optic neuropathy. So what happens that the nitrous oxide, it kicks out the heme molecule, and this will result in inadequate vasodilation in the blood vessels and in patients with MELAS, resulting in during the attack it will produce reduced will describe that in a minute. So this is a muscle biopsy of patients with MELAS. As you can see, there are some basophilic material inside the muscles, and that's correlated for the right fibers thing. And when they stained both the muscle fibers as well as blood vessels for the succinate dehydrogenase, and it showed reactivity, and this is common for all mitochondrial diseases. But when they stained it for the COX, which is cytochrome C, there will be an increased staining in patients with MELAS compared to patients with other mitochondrial diseases. So now let's go with the clinical features of these hereditary disorders. So what characterizes these clinical disorders? They usually resist treatment, and they are progressive, recurrent strokes, and they contain plenty of multisystemic involvement. So the most important, like neurological features, brain with aura, especially Cadazell, Heron's, MELAS, Moya disease. So cervical dissection can present with migraine-like headache and occasional auras. Dementia, subcortical type, especially in Cadazell and Fabry disease. Epilepsy, patients with MELAS, Cadazell. Mood disturbances, as in patients including depression, bipolar state, as well as pseudobulbar effect, can occur in these in Cadazell and Heron's. Painful neuropathy, and it usually occurs in Fabry disease, usually in younger population, up to the younger age group. Vascular changes to leukophthasias of the vascular and vertebral arteries. Patients with Fabry disease, premature atherosclerosis, homocystinuria, as well as patients with Fabry disease and pseudoxanthoma elasticum, aneurysms with connective tissue disease like Marfan syndrome, as well as Ehlers-Danlos syndrome type 4. Skin manifestations, angiokeratoma, corporis diffusum, which is manifestations of Fabry disease. It's characterized by violaceous kind of skin lesions, and they are clustered, especially in the periumbilical area, as well as the gluteal region and the thighs. Livedo reticularis, it's found observed in homocystinuria, as well as in patients with Sneddon syndrome and then phospholipid syndrome. Pseudoxanthoma elasticum, they develop yellowish vacuoles over the nape of the neck, and it's more of linear in shape and found in the lateral aspect of the neck, in the axilla, as well as the bone. Cadazell patients, they develop alopecia, as well as skeletal deformities and back pain, and anhydrosis in patients with Fabry disease. This is the angiokeratoma diffusum. As you can see, the distribution that I mentioned about. They are very small vacuoles to be checked. This is the yellowish vacuoles of Pseudoxanthoma elasticum. As you can see, the lateral aspect of the neck. They are small, but they are clustered, so that become more of a streakingly linear. With time, with aging process, and there will be more of a wrinkling and sagging of the skin in patients with Pseudoxanthoma elasticum. And as you can see over here, it's more of a sagging in nature, and it's more of wrinkling. Livedo reticularis is more of a meshwork of blood vessels. Ocular manifestations, it can, like in patients with hereditary disorders, like from the anterior apparatus, the retina can be involved. And the patients with they found that tortuous blood vessels in patients with Fabry disease, in both the eyelids as well as in the conjunctiva. And they in one recent study, that the eyelid tortuosity, they found it occurs in up to 94% of patients with Fabry disease, and compared to the general population, which is not. Lenticular ectopia lentis occurring with patients with Marfan syndrome and hyperhomocystinemia, and cornea vitellata, which is occurs in Fabry disease. This condition doesn't affect the vision. They can have been abnormalities. There will be a drop out of the macula, as well as telangiectasia and microaneurysms develop. Pseudoxanthoma elasticum will produce angioid streaks. This is the ectopia lentis, and as you can see, there is, like, the lens is not in its place, it's displaced. So, and this is better to be appreciated after dilatation. And these are the cornea pistillata. As you can see, these are streaks on over the cornea, like more of a sun-shaped kind, but these doesn't affect the vision. These are the vascular tortuosities. For me, I don't have to appreciate. I do not appreciate it, but it becomes more apparent when it's more of a moderate degree. These are suggestive of Fabry disease. These are the angioid streaks. As you can see, it's more of a yellowish deposits with development of intrusions in the retina in patients with pseudoxanthoma elastica. Renal manifestations with renal dysfunction, proteinuria, can happen. So, Cadazil, which is, as we had mentioned about, it's due to notch-3 gene mutation. It starts usually between 20 to 40 years of age, and it starts with migraine with aura in 20 to 40% of patients, and this can precede the MRI findings. Later on, the patients start to develop more of a subcortical strokes and lacunar strokes, and in 60 to 80% of these population between 4th and 5th decade of life. It can produce more of isolated symptoms like ataxia, non-fluent aphasia, hemianopia, etc. But vascular risk factors also occur in a high frequency of these patients: 50% for smoking, 20% for hypertension, 20% for hyperlipidemia, and 4% for diabetes. And with time, like when the patient reaches 60 years of age, they will start to have 60% of these patients, they will develop dementia. This is more of a subcortical changes. Executive dysfunction can occur earlier on, even before the stroke started to happen. And eventually the patient develops pseudobulbar effect. Of interest, that patients with Cadazil, just like that any neurodegenerative disease, doing optic OCT, it will reveal degeneration of the retinal fiber layer, but the clinical significance of this finding is not what it doesn't predict anything, but it's just an interesting finding. So this is the natural course of patients with Cadazil. As you can see, it starts with a migraine with aura, and then with progression, with aging, ischemic strokes start to happen, and with time, the apathy and dementia and motor disability, which is the eventual feature. Parents, it starts with the 3rd and 4th decade of life, starts with the visual changes, visual loss. Central vision started to be loosened, and this is very gradual to happen. And there will be more of a tortuous telangiectatic vessels, and fluorescent retinal angiography can demonstrate these changes. 10 years later, 8 to 10 years later, the patients start to have strokes, more of subcortical kind, and they may coalesce to form as tumor-like lesions and with surrounding cerebral edema, and may be confused sometimes with brain tumors. And one half of the patient, they will develop renal dysfunction and proteinuria. This is a retinal angiography of these patients. They mentioned that in this article that there is a dropout of the capillaries, and there is increased tortuosity of the retinal blood vessels. And I'm not sure if these are microaneurysms or not. Fabry disease, we discussed the etiology as well as the mode of inheritance. Now, the natural course of the disease, they start initially with angiokeratomas and all the skin manifestations, and with the progression of the disease, they will start to have more of retinal changes, renal changes, cardiac changes, and eventually they will develop the strokes. Or around 40 to 50 years of age, they will develop the strokes. The strokes in Fabry disease are predominantly in the posterior circulation, and 20% of them are in the anterior circulation, and they're more of like subcortical strokes, although large artery strokes can happen due to artery-to-artery embolism. The leukoktasias, it's hard characteristic. The leukoktasias, which is dilatation of the blood vessels, and the basilar and vertebrovascular leukoktasias, there are more common conditions that can produce that, like hypertension, of course. So the leukoktasias produce mainly more of a compression kind of symptoms, neuralgias, hydrocephalus, and nerve pulses. ICH can often happen, but it's uncommon. So the more, as we have mentioned, coronary artery disease as well as conduction deficits can happen. And in new clinical science, we discussed the eyelid tortuosity in patients with Fabry disease. This is the natural course of the disease, and as you can see, initially starts with acroparesthesias, followed by angiokeratomas and hydrosis, diarrhea, proteinuria, heart problems, strokes around 40 to 50 years of age. Pseudoxanthoma elasticum, it's an autosomal recessive disorder, and it's a very rare due to ABCC gene mutation. It starts with more of the skin manifestations like the yellowish papules, chronic granulomas can develop in these patients, and then they start to develop more of the retinal changes, like the retinal changes like the angioid streaks and drusen's in the retina, and the skin starts to degrade and become more lucent and hanging at the axilla as well as in the folds. GI bleeding due to fragility of the skin as well as calcification, resulting in GI bleeding and anemia. And eventually, patients with pseudoxanthoma elasticum will develop accelerated atherosclerosis due to development of hypertension, and they will develop coronary disease, peripheral vascular disease, as well as strokes. The strokes in patients with pseudoxanthoma elasticum are more of a small vessel disease type, and but may develop also peripheral atherosclerosis resulting in artery-to-artery involvement. So, homocystinemia and hyperhomocystinemia is due to mutations in the MTHFR gene as well as cystathionine beta synthase. The significant level of hyperhomocystinemia is 10.2 millimole to produce that. So, some patients they will have like renal impairment, aging, B12 deficiency, and this will increase the homocysteine level to around 2 to 4 times. But this is not a significant degree to produce increased atherosclerosis and to be tested for genetically to check for these genetic mutations. So the cutoff point that they think is 10.2 millimole to test for these genetic mutations. Okay. Of course, hyperhomocystinemia affects the collagen synthesis, and it can present with a marfanoid-like picture with aneurysms as well as dissections. And the mechanism of stroke in these patients is dilatation of the blood vessels and throwing emboli. Ehlers-Danlos syndrome is another connective tissue disease, and Marfan syndrome is another connective tissue disease. Usually they present with dissections as well as artery-to-artery involvement. MELAS, well-known stroke-like episodes. We discussed the pathophysiology of that, and they present usually with hemianoxias, cortical blindness, hemiparesis, aphasia, and usually it's precipitated by infection or a fever. The other manifestations of MELAS, just like other mitochondrial diseases, muscle problems, cardiac problems, sometimes endocrine dysfunction, as well as hearing loss. This is the criteria for MELAS: 6 core features: age, less than 40, encephalopathy, exercise intolerance, lactic acidosis, drug-related fibers, stroke-like episodes, free additional, which is a minor neurodevelopment and recurrent poverty. These are manifestations of common features of MELAS. So this is a summary of all these clinical features, so that we divide the patients initially for either small vessel disease or large vessel disease, and then depending on the corresponding features that correlating with them, like what kind of cognitive changes that they are having, if they have any eye manifestations or skin manifestations, that will further approach the patients and reaching a diagnosis for that. So now, start with this tests like lactate serum and CSF have been found that to be elevated in patients with MELAS compared to normal subjects. Alpha-galactosidase levels as well as triacetylamide. These are used for Fabry disease to screen patients before going to genetic testing in suspected cases. Although this is maybe may not be, it will be difficult for patients, for female patients who are heterozygotes for alpha-galactosidase, and maybe need to go to the genetic study immediately. MRI, like Hereditary, and Fabry disease, are very important. As you can see, this is the MRI for patients with Hereditary. As you can see, the anterior temporal lobe is involved, and it's found in up to 66% of patients with Hereditary, and it's fairly specific for this disease. Along with that, the external capsule being involved, or here, as well as you can see, there is diffuse This is the Hearns MRI. As you can see, there is an area of contrast enhancement, and with time in this patient, it got more of a big kind of cerebral edema, and the patient was confused to get that he had brain tumor. This is Fabry disease. As you can see, there is a dilatation of the vertebral artery as well as the vascular artery producing epistasis. And they mentioned about Bulvinar sign, which is more suggestive of Fabry disease, in which there is a hyperintensity in the thalamus. 21. This is the MRI for MELAS. It doesn't correspond to any kind of vascular territory, and it's more of a gyroform kind of picture. And when they did the diffusion rate, it can reveal hyperintensity, and if you do an MRS, you will find a lactate peak in that region. And as we have mentioned, increased lactate peak for patients with mitochondrial disorders, and when compared to controls, even normal appearing white matter have changes in patients with Fabry disease, with increasing Na peak to creatinine ratio and Na to choline ratio, but not choline to creatinine. Skin biopsy. Now, once the patient have been suspected that to get a specific form of like he had small vessel disease, and there's features suggestive of cadism. This is diagnostic. It reveals eosinophilic and fast positive stains, and on the electron microscopy, the granular automotive material can be detected. Parents, we mentioned about the laminated vascular basement membrane, pseudoxanthoma elasticum. We mentioned about the degradation of the reticular dermis as well as calcification with dystrophic calcification. And in Ehlers-Danlos syndrome, it's qualitative and quantitative for the amount of collagen. Genetic testing. In order for genetic testing, there is a recent study published in 2012 about screening for a score for cadism, and this corresponds for many numbers, as you can see, and they found that the cutoff point is around 15, and after which you can the genetic testing can be approached for, and it will be more cost effective to depend on this rather than to go ahead and test it for the gene immediately. This is an algorithm for busy algorithm for patients with Fabry disease, and initially they start with the clinical manifestation that may be suspected. Then they will go to the blood test, the serum test for the alpha-galactosidase activity as well as the global triacetylamide levels in the serum. And if it's elevated or there is a reduced alpha-galactosidase in the leukocytes, then they go to the mutation testing. And then the mutations, there are a huge number of mutations in Fabry disease. Some of them they have of unknown significance, but there are some certain mutations that have been found to be correlated with Fabry disease. PET scan in Fabry disease, that it has been found that there is an increased cerebral blood flow related to increased vasodilatation in patients with Fabry disease and with reduced regional glucose metabolism. With enzyme replacement therapy, these changes have been reversed, and indicating that it's more of vascular reactivity also plays a role in the patient with Fabry disease. Nitrotyrosine staining of the blood vessels. So they found that it gets reduced. Like when it's stained in patient with Fabry disease, it will be very bright. This is the nitrotyrosine. As you can see, this is the nitrotyrosine stain, and it's like very bright compared to the control over here. Now, with the patient got ERT, this got significantly reduced, which is enzyme replacement therapy. And it's thought to be due to nitric oxide pathways and vasodilatation, and with the ERT, there will be reduced nitrotyrosine activity, resulting in more vasoconstriction. So specific management, patients with hereditary vasculopathy, just like any kind of stroke, you do the same management for them. But whenever they have like a specific genetic defect, you start to treat that. For Fabry disease, there is the alpha-galactosidase A infusion have been used, and they found that it reverses or reduces staining as well as the PET scan changes in patients with Fabry disease. It's changed. That means that it can have an effect also in patients to reduce the risk of stroke in Fabry disease patients. Vitamin supplementation for homocystinuria, they found that there is a variability of the results of the studies. Some studies mention that it has a moderate effect. Some studies there is found there is no association with homocystinuria. L-arginine infusion in patients with MELAS, and it has been found that L-arginine is more of a donor for nitrous oxide, and that we have mentioned for mitochondrial angiopathies, there will be a defective vasodilatation in patients with MELAS. So you get, and they have been found that they have low levels of arginine in the serum, and that giving them that, they found that this will improve the changes in the PET SPECT as well as for the hemodynamics of the brain. And there are other treatment options for MELAS like citrulline, coenzyme Q, and corticosteroids. So of course, the L-arginine in patients with MELAS, it can produce severe hyponatremia due to nitrous oxide surges, as well as it can produce severe hypotension, and that needs to be really avoided. Gene therapies have been implicated for Fabry disease patients with adenoviral vector donor and get a replacement for the mutated gene. One of the interesting approaches for patients with Fabry disease is pharmacological chaperone therapy. And in these patients, it's a molecule that affects the conformational change of the mutated Fabry disease gene and makes it more excretable as well as more functional. And they found that it is effective in these preliminary studies. This is a cartoon for this. As you can see, this is a normal one, and it goes and excreted, while in this here, it goes misfolded. It's mutated and misfolded, and it goes and degraded. So this chaperone goes and changes the conformational change, makes it more excretable and functional. So conclusions. So hereditary causes are rare. Approach start with the correct classification of the stroke syndrome, as well as identification of the correlated features, and they need to be considered in patients with recurrent strokes, progression of symptoms, as well as resistance of conventional treatment. Skin biopsy needs to be done in patients with suspected hereditary vasculopathies.
So from a pathology perspective, if you were to get a biopsy from any of these patients, I mean, it apparently takes a lot of planning and collaboration to appropriately use the biopsy, and a lot of luck too to get those vessels on the EM, for instance, to identify certain structures. That's my conclusion for my part, but are there any?
Yeah, it's just like as you mentioned, like it may be missed, especially if there is we sent, for example, hereditary vasculopathies, and we did not mention specifically to test for Fabry disease or to test for Hereditary, it will be missed. So
yeah, because of times nobody really knows anyway to start with, and so that makes it all more challenging.
That's why it's more of a clinical diagnosis. Like we depend heavily on the clinical part and the indirect evidence before we go to the pathology. But
well, you're not going to screen like a 75-year-old person who comes in with a stroke for any of these things. So what is the recommended age cutoff below which you should investigate for?
So it's all, yes, these hereditaries, usually below 40 years of age, they present with a stroke. But it's some reported cases here and there, they reported some strokes due to Fabry disease or Cadazil in the 7th decade. But these are very rare. So they recommend, I think it's in 40 to 50 years of age to be screened for, but after ruling out other more common conditions, because it's not really cost effective to test for the genetic defects, which is very rare in the first place. And to have the approach like the screening for Cadazil, the table that I show, or the approach for like very detailed physical examination examination to check for other signs of these genetic conditions.
Thank you. Before people leave, if you can pick up a review form so we can give Dr. Al-Salaimeh some feedback on his talk, that would be great. Go right up there to feedback.
I had several thoughts. I got it. I had several thoughts. None were appropriate in university even. So I apologize that I didn't respond. Sorry. I did see the images. That's why I'm saying. No. I'm kidding.
I will let you know.
I just don't have anything to say.
They won't know who linked this to CME to you. Yeah, so you download this, you put it in, and then what you need to do is get the department IT person to register themselves.
Exactly.
Young copy.
Yeah, we also right. I've seen Fabri's disease.
So, yeah, you can contact both of them. Both of them, it's okay.
We used to have, so this is like no, in Jersey. So my boss, like he used to do a lot of Fabri's disease research. So we had a mother and a son come. Oh, I have neuropathy and blah blah blah. They have typically small fibrosis for neuropathy. So they had done. They knew that this is Fabri's disease.
Sorry I missed your talk.
Yeah, but then this is what I have. In fact, he was educating me. Wow.
Dr. Archer and I both have this monthly meeting, and sometimes it gets done at 8:30, and sometimes it goes later.
Did you see that patient? Headache better?
I have to go and see her. She's going out of my service. I don't know what to see. I don't know what to do.
You did your duty.
I called you.
Fact findings, those two were really good.
I'll have an exchange.
You know what I'm talking about?
I'm not in charge of them. You're allowed to exchange it. But see, whosoever else is doing it, and just see, when is your random?
Wait.
No, come with me. I think I want to change with you because. No, mine is in March, and I'm going to do Hereditary, and I don't want to do it in March. I want somewhere in that. Is it? I want to do that mine in somewhere in May. Yeah, so I'll see. I thought that you would do it.
If it's going to be with me, then it's with me.
Yeah,
That was more.
Yeah, I can't do that. I can.
Oh, yeah. I was actually more organized.